Open the slides.
Yes, sir. Yeah,
Slides.
Fine. Good evening, students. Today I'll be taking the
Slides
topic
madam.
on. Yes, sir. I'll do that. Yeah. So I hope you're able to see the slides now.
Yes, madam. Okay.
Yes,
Yeah.
ma'am.
Okay, so as I said earlier, today I'll be taking the topic on ectopic pregnancy. This is the part 2 of the same topic. We have covered it in the previous class, the first part of it. So what I'm doing in this class is like I'm trying to take up more questions, the multiple choice questions on this topic, and along with the same slide, the same question, I'll be explaining the theoretical part of it relevant to that. So just to brush up the previous slide of the last slide which we did in the previous class, we had stopped at this point where we discussed about the diagnostic aids in ectopic pregnancy. So quickly, I'll just go through this slide once again because the next few questions are based on this. So as I told, the diagnosis of ectopic pregnancy is always based on a very important point, that is you always have to have a great or very high suspicion of ectopic pregnancy. So whenever a patient coming to you with amenorrhea, pain abdomen, and the triad of vaginal bleeding, these are the three classical symptoms the patient will come to you of an ectopic pregnancy, and immediately once there is a history of these three important symptoms, you should always have a high suspicion of ectopic pregnancy and evaluate the patient for the same. And of course, once the based on the history, if you have suspected an ectopic pregnancy, subject her to several tests. First will be an urine pregnancy test, which will be positive in about 90% of the cases of ectopic pregnancy. But the most important and the investigation of choice is the TVS, that is the transvaginal sonography, which will confirm the presence of ectopic pregnancy, its location, and also confirm that it is not intrauterine, in the sense the absence of the gestational sac in the uterus, the presence of an adnexal mass either on the left or the right side, the presence of any free fluid in the pouch of the egg loss, which indicates that there could be a rupture of the ectopic pregnancy. And other important sign on TVS examination when we do, apart from these important images, is that the tenderness. So the probe tenderness is also very, very important sign when you're doing a TVS, which will indicate the presence of ectopic pregnancy. So these are the two important tests. The supportive investigations include Doppler ultrasonography, which is again done along with the same the TVS examination. When you put up the Doppler, you will be able to see the important aspect of color flow within the adnexal mass. Whenever you have a doubt of that adnexal mass being something like a cyst or any other benign mass, then the presence of the color flow when you put up the Doppler and high suspicion of ectopic pregnancy with the UPT positive, it definitely indicates that there is a pregnancy tissue or a sac in the adnexal region, and that will help us to identify that the presence that is there is an increase in the color flow that helps us to diagnose in the Doppler ultrasonography. Beta HCG levels are another important investigations where why do we do beta HCG after, of course, the UPT being positive in some cases of ectopic pregnancy, we still do beta HCG levels to know exactly what is the value. Because two things what you have to remember regarding the beta HCG levels in ectopic pregnancy is, one is the levels will be lower than the normal pregnancy corresponding to the gestational age, and second is that there is no doubling of the beta HCG levels, which normally occurs in 48 hours time in a normal pregnancy. That doubling is not there, and the values of the beta HCG are lower than the normal pregnancy. So that is why we do a beta HCG level, and which will indicate the presence of the ectopic pregnancy. Serum progesterone levels we routinely don't do, only in the research settings we do that, and the normal values in pregnancy should be more than 25 nanograms per deciliter. If it is lesser, it indicates that the pregnancy is abnormal or it is an ectopic pregnancy. So it's not very specific. Both the beta HCG and serum progesterone levels are not specific to ectopic pregnancy, but they aid us in the diagnosis when we have other important aspects, that is the clinical history and the TVS examination. Culdocentesis, again, it will help us to identify if there is a rupture or no, or if there is any collection within the POD, and if at all there is a collection in the POD on the ultrasonography, and if you do a culdocentesis and you are able to aspirate the blood frank blood which does not clot, and when you keep it on the bedside, that indicates that there could be ruptured ectopic. The presence of the blood, or when you aspirate blood on caldosynthesis, is again an indication that it is a ruptured ectopic. Of course, the gold standard for diagnosis of ectopic pregnancy is laparoscopy, where you will be able to identify exactly the presence of the ectopic, whether it is tubal, which part of the tube, or it is ovarian, whether it is intact or ruptured, or if there is ruptured, what is the amount of the blood within the peritoneal cavity. All these things can be assessed, of course, on the laparoscopy. So this is briefly about the diagnostic points in the ectopic pregnancy. Now we continue with the next questions. Now, most valuable diagnostic test in case of suspected ectopic pregnancy is. Students, I want you to be interactive here. I will read out the question and I want you all to answer as quickly as possible so that we cover the maximum question answers today. And I want you all to be very interactive, and I hope you all are able to listen to me. I don't want it to be a one-way thing. You're all there, students, with me?
Yes, ma'am.
Okay. Only one voice I could hear. What about others?
Yes, ma'am.
Yes, please open your, on your mics so that you all will be able to answer quickly. And as I go through the questions, please answer, right? So going ahead, most valuable diagnostic test in case of suspected ectopic pregnancy is A, serial beta HCG levels, B, transvaginal ultrasonography, progesterone measurement, or D, caldosynthesis. Anybody with the answer? We just discussed this point in the previous slide, which is the most important diagnostic test in case of suspected ectopic pregnancy. Yes, students? Anybody?
Transvaginal USG.
Yeah, transvaginal USG is the right answer, because as I told in the previous slide, this is one important investigation which will confirm the presence of the ectopic pregnancy. You will be able to identify an adnexal mass, sometimes gestational sac if it is unruptured ectopic pregnancy. You will be identifying whether it is ruptured or unruptured based on the collection in the POD, and also the documentation that the intrauterine cavity is empty and there is no sac within the uterine cavity is again an important point towards the ectopic pregnancy. So transvaginal sonography is the most important case in diagnostic test for ectopic pregnancy. Now all other things, as I told, they're all supportive tests, where just based on serial beta HCG levels we won't be able to diagnose the ectopic pregnancy. Similarly, progesterone measurement or caldosynthesis. So all these are non-specific tests and they won't be able to help in exact diagnosis. So transvaginal ultrasonography is the correct answer for this. Next one, true statement regarding ectopic pregnancy. A, serum progesterone should be more than 25 nanogram per ml, which excludes ectopic. Beta HCG level should be more than 1000 ml per international units per ml for earliest detection of TVS. Beta HCG level should be 1500. Methotrexate is used for treatment. Beta HCG double in 48 hours. Remember, this is a PGI question, and here more than one answer is a right answer. Yes, students? I'll read out the options again and tell me the right options. A, serum progesterone levels more than 25 nanogram per ml excludes ectopic. Is it true or false? What is the normal serum progesterone levels in a normal pregnancy?
Greater than
20
25.
nanograms.
Yeah, normal pregnancy, the serum progesterone level should be more than 25 nanograms. So if the serum progesterone level is more than 25 nanograms, it definitely excludes ectopic pregnancy. That is an abnormal pregnancy, is it not? So the first statement, that is A, is the right answer for this one. Agree?
Yes, ma'am.
Yeah, next one, B, beta HCG level should be more than 1000 milli international levels for earliest detection by TBS. Is it a true statement or a wrong statement? What is the value of the beta HCG necessary where you will be able to see a gestational sac by the TVS ultrasonography?
1500.
Yes?
1500 international.
Yeah, so that's the right answer. So there are studies which have been documented that when the beta HCG levels is about 1500, then they will be able to identify the earliest sign, that is the presence of the gestational sac by the transvaginal sonography. Whereas for transabdominal sonography, the value is 6000. So when the beta HCG level is about 6000 international units, that time we will be able to identify gestational sac on transabdominal. Whereas 1500 is for the TVS. So the answer B is also right, because as I mentioned that more than 1000 milli international ml per ml is the beta HCG levels should be present for detection of the TVS. So that's a right statement. Now coming to the C, beta HCG level should be 1500. So this is a very straightforward statement. Beta HCG levels should be 1500 for ectopic pregnancy. Do you think it's the right statement or wrong one? Yes,
Right.
anybody?
Right.
It's actually not true for ectopic pregnancy. You know, in ectopic pregnancy, the beta HCG levels need not be 1500. They could be lesser than 1500 also. So that's why this statement is wrong. It doesn't mean that when the beta HCG level is more than 1500, the ectopic pregnancy is present. So sometimes it could be even lesser in ectopic pregnancy. So this statement is not right for the answer, for the question. Now, the next one, D, methotrexate is used for the treatment. Is it used or no? Yes, students? I hope you're all there with me. Hello? Hello?
See the screen.
You're not
Ma'am,
able to
we
see the
can't.
screen?
Yeah, ma'am, we can't. Not able to see the screen.
PPT, you're not able to see the PPT?
No, ma'am, the PPT screen I am not able to see.
What about others? Are
If
you?
you press some other button, it will lose. It just screen is actually seen. Select the madam's ask PPT screen. Actually, it is seen. You must have
Yeah,
seen.
because everybody else is seeing, is able to see. There must be some problem in your handset or
You have to
in
click
your
that
setting.
screen only. If you click somebody else button, that person's profile will come up.
No, sir.
Okay.
Actually, everyone's profile it is showing
So you need
in
to
the
press on
box
my
form.
profile.
Okay. Actually, I am able to see the screen, but hold on, I'll log in with. I'm able to see the screen actually.
ये सब आप डाउनलोड करवा दिए कुछ नहीं हो रहा गूगल मीट छोड़ के
You need to probably
see
click
meet
on
पे है
on my profile, and probably you'll be able to see whatever I'm presenting.
देख रहे कर रहा है
Hope,
गूगल मीट से
hope you got it.
Yes, ma'am. Yes, ma'am.
Did you get it? Sure. I'll
Yes,
just
ma'am.
continue. If not, you please try it, okay? Because other people
Okay,
are
ma'am.
able to see, and I'll
Yes,
just
ma'am.
continue
Yes,
with
ma'am.
the presentation, right?
Yes, ma'am. Yes, ma'am.
So we were at this point. That is the methotrexate is used for the treatment. Students, you didn't answer, any one of you. Methotrexate is used for the treatment of ectopic pregnancy or no?
Yes, ma'am. It is given.
It is used, is it not? So it is one of the drugs of choice for the medical management of unruptured ectopic pregnancy. So this statement is also correct. Now, beta HCG double in 48 hours. Does it double in 48 hours in ectopic pregnancy? Yes or no?
Yes, ma'am.
It doubles in ectopic pregnancy in 48 hours?
No, ma'am.
It's no, actually. It's not yes. Because only in normal pregnancy, the beta HCG will double in 48 hours. In any other abnormal pregnancies, it could be ectopic or abortion. It doesn't double in 48 hours at all. So this statement is also wrong for ectopic pregnancy. So when you consider this question, true statements regarding ectopic pregnancy is A, that is serum progesterone of more than 25 nanogram per ml excludes ectopic. B, that is beta HCG level should be more than 1000 milli international units ml for earliest detection by TVS. And D, that is methotrexate is used for the treatment. So these are the three correct answers for this question, right? Next one. So that is the whatever we discussed. Next one. True about ectopic pregnancy. Is this again a PGI question? Remember it more than one answer. Option could be a right answer. Transvaginal ultrasonography, first imaging test of choice. B, associated with residual reaction. C, Doppler is of no significance. D, in ectopic, interstitial ring sign is seen. HCG level is sufficient for diagnosis. What are the right statements amongst these five?
A is correct.
A is correct. That is transvaginal ultrasonography is the first imaging test of choice is correct. What about B? Is it associated with residual reaction?
Yes, ma'am.
Yes, is it not? Because anywhere the pregnancy could be, the hormones whichever will be secreted once the pregnancy or the chorion develops, the progesterone as well as the HCG will be secreted, and they will definitely have an action on the uterine endometrium, which will convert the uterine lining into a decidual endometrium, and therefore there will be an associated decidual reaction in ectopic pregnancy as well. So this statement is also correct. Now, Doppler is of no significance.
False, ma'am.
False, is it not? Because Doppler is of significance. So whenever we have a confusion in case of an adnexal mass, the Doppler, when we put up, as I told earlier, it will give us the indication when there is a increased color flow in that particular lesion, will indicate that there is definitely a low resistance tissue, that is a chorionic tissue, is present in the adnexal region. So Doppler is of significance in ectopic pregnancy and is an important aid in diagnosis. Next one, in ectopic, interstitial ring sign is seen. Is it correct? If you all can remember the ultrasonographic pictures of different ectopic pregnancies, there are different patterns have been explained, like the ring of fire sign or the tubal ring sign or the interstitial ring sign and all that. So if any of you have read about it, you'll be able to answer this question. Anybody? Is this statement true? That an interstitial ring sign is seen in the ectopic? This is an ultrasound finding actually. Nobody's answering, so I'll give you the answer. It is true actually. So you will be able to see an interstitial ring sign or a tubal ring sign on ultrasound in some of the ectopic pregnancies where it is unruptured most of the times, and you'll be able to see a proper gestational sac within the tube. I'll show you some of the pictures so that you can understand that. Now, HCG level, the last one, that is HCG level is sufficient for diagnosis, is actually, it's not a correct statement, is it not? HCG level is not sufficient for diagnosis. We have to rely on the other diagnostic methods as well. So the answer for this question, as I told, true about ectopic pregnancy is A, transvaginal ultrasonography first imaging test of choice. B is associated with decidual reaction. And D, that is in ectopic interstitial ring sign is seen. Okay. Now here are some of the pictures where you will be able to identify how the fire of the ring
Ma'am,
of fire
trans
sign.
abdominal ultrasonography, no, ma'am. Transvaginal.
Which one? Which one? Sorry. Sorry, I didn't get your question. Yes.
Transvaginal, trans abdominal we will do, no, ma'am, for
Yes.
ectopic. Ma'am, trans abdominal we will do, no, ma'am, than transvaginal ultrasonography.
No, the preferred investigation is transvaginal only.
Hello, ma'am.
Yes, are you able to listen?
Trans abdominal ultrasonography is better, no, ma'am, than transvaginal.
No, actually transvaginal is better than transabdominal because the clarity of the picture will be much better with transvaginal. And as we discussed that, in the transvaginal sonography, we will be able to pick up the pregnancy findings almost 2 weeks earlier than transabdominal. And the window of the clarity of the window will be much better in transvaginal sonography.
Given transvaginal, how it is correct.
Your voice is breaking. Sorry, I'm not able to completely hear what you're speaking actually. Are you able to hear what I'm talking?
Yes, ma'am.
Yeah.
Yeah, ma'am,
The
I
person
got
who
the
was.
answer for that question, ma'am. Thank you, ma'am.
Yeah. Okay, fine. So you're clear, right? See, transvaginal sonography is actually the preferred one. Though the patient will have some
Yes,
amount of
ma'am. Yes, ma'am. I
tenderness,
can hear you.
though she'll have some amount of tenderness, we would prefer that before we go for a
Yes, ma'am.
transvaginal.
I got the answer.
Okay. So here in
Yes.
this picture, you're able to see this ring of fire sign, which is typically seen when you put up the Doppler, color Doppler, when you're doing the ultrasonography. And you'll be able to see in this is in the adnexal region, when you're able to see
Yes, ma'am.
there is a small sac, and around the sac, when you put up the color Doppler, you'll be able to identify the blood vessels arranged. So this is a typical ring of fire sign, which is seen in the ectopic. As I discussed, these are all the options what we discussed and how we can identify the right and the wrong statements. So another important sign in the ectopic pregnancies is the tubal ring sign or the ectopic tubal ring sign. Now in this picture, you can see that this is an adnexal picture. You can see this the left ovary. How you can say that this is the left ovary? You can see some small follicles here, and this whole thing is the left ovary actually, and you can see a small gestational sac like thing in the next to the left ovary, that is the left tube. So within the tube you are able to see a small ring like structure, so that is why this sign is called as the ectopic tubal ring sign. So this is the left ovary. Now the same thing, if you can see in these three images, this is in the plain B mode, where you're able to identify some gestational sac-like structure within the adnexal region. And when you put up the Doppler, the same thing, you can see the blood vessels all around the tube. This is the tube actually, and then the gestational sac here within the tube. And this whole thing is the color Doppler, which shows the increased blood flow around the tube, around the gestational sac. So this is again the same thing here. So this is how you can identify the unruptured ectopic pregnancies on the ultrasonography, especially the TVS and the Doppler. So remember these signs. One is the ring of fire sign, and the other one is the tubal ring signs, which are present in the ectopic pregnancy. Okay. Now, next question. About ectopic pregnancy, true statements are: rising titer of HCG, negative pregnancy test excludes the diagnosis, common after tubal surgery, seen in patients taking GnRH therapy, common in patients taking OCP. Again, this is a PGI question, and multiple choices, multiple options will be right answers here. Anybody? What about A, rising titer of HCG? Will there be a rising titer of HCG in the ectopic pregnancy?
No.
See, the statement is important here. You have to remember that they have just asked rising titer of HCG. They have not asked doubling titers of HCG. So this actually is the right answer, because to some extent, until the ectopic ruptures, the HCG titers will be rising, though not up to the level which they are found in the normal pregnancy, but definitely there will be a rising trend in the beta HCG levels. So actually this statement is correct in case of ectopic pregnancy. Remember, the rising trend will not be as in normal pregnancy, that is doubling every 48 hours, but there will be a rising trend of beta HCG. Okay. Now, the second one, negative pregnancy test excludes the diagnosis.
False.
False, is it not? Because in 10% of the cases, as we discussed earlier, in ectopic pregnancies, 10% of the cases, the beta HCG, or the urine pregnancy test could be negative. So, of course, a negative UPT does not exclude ectopic when you have a high suspicion. Third one, that is C. Common after tubal surgery?
Yes.
Yeah,
Yes,
it's
ma'am.
very common after tubal surgery, because as it is, there will be a scar on the tube, and definitely there will be high chances whenever there is a pregnancy post tubal surgery. It could be in the form of a salpingostomy or tubal recanalization surgery. So most of the times, whenever there is a pregnancy post tubal recanalization, there are very high chances of ectopic pregnancy, and you need to counsel the patient very thoroughly regarding this possibility, and whenever she conceives or whenever she misses a period, the first thing she has to immediately report, and we need to confirm the site of the pregnancy, especially in case of post-recanalization procedures. So any tubal surgery will definitely increase the chances of ectopic pregnancy because of the scars and the pregnancy coming in they get stuck at that level. So it's quite common after tubal surgery, or even tubal surgery here. It could even be tubectomy, right? Not only other surgeries what I mentioned. Tubectomy actually is the most common tubal surgery. So any patient after tubectomy coming to you with a missed period, always we have to rule out ectopic pregnancy. So that's important. Now the next statement, that is seen in patients taking GnRH therapy. Is it true or false? GnRH therapy is given for patients mainly for induction of ovulation, or it is given in post perimenopausal patients for fibroid. But most of the times it is given for, the GnRH therapy is given for ovulation induction in reproductive age group. So is it seen that the ectopic pregnancy is higher with patients with GnRH therapy? Anybody? It's true or false?
No, false.
It is actually true. Okay, the incidence of ectopic pregnancy is higher in patients who are receiving a GnRH therapy for ovulation induction. Okay, so this is a true statement. The last one, that is common in patients taking OCP, is it true or false?
True.
This is false actually. You know, the patients who are on OC pills, it's the, whenever you consider the contraceptive methods and the incidence of ectopic pregnancy, remember OC pills are the least the least associated with ectopic pregnancy. The method, amongst the different methods of contraception, when you consider copper T or tubectomy, they are all associated with high incidence of ectopic pregnancy, whereas oral contraceptive pills are associated with a very low incidence of ectopic pregnancy, or they almost nil. So this is a wrong statement. It is not common in patients taking OCP. So remember, the right answer for this question, the true statements about ectopic pregnancy is, one is it is common after tubal surgery. The rising titer of HCG is right answer to some extent, as I discussed, and it is seen in patients taking with GnRH therapy. Clear to all of you?
Yes, ma'am.
Right. So that's the same thing what we discussed. Coming to the next question. Drugs used for treatment of ectopic pregnancy are MTX is methotrexate, actinomycin D, HCG, RU486, that is also mifepristone, and KCl, that is potassium chloride. So these are mainly for the medical management of ectopic pregnancy. Anybody with answers? Again, it's a multiple true answers here.
A and D.
A, of course, methotrexate. You should all remember that methotrexate is the drug of choice for medical management of ectopic pregnancy. Any other drugs which have been tried?
Ma'am, E. Potassium chloride.
Potassium chloride, yes, that's one of the important drugs which they have tried for ectopic pregnancy. Mainly, it is used as a surgically administered, medical drug, that would what we call it as SAM, surgically administered medical management of ectopic pregnancy, where the KCl is injected into the ectopic sac. Either through transvaginal guidance or sometimes laparoscopically also. Any other indication for KCl in obstetrics? Anybody? Where else is KCl used in obstetrics? Now, as I told that they inject this KCl into the ectopic gestational sac. Okay. So any other indication where they use this KCl in obstetrics? Anybody? It is used in fetal reduction. Okay, in IVF pregnancies, they usually instill more than 2 embryos, 2 or 3 embryos sometimes. So that the chances of pregnancy are higher. They do 3 embryo transfers, 4 embryo transfers. 3 is the most commonly done number of the embryo transfers. So when they do the 3 embryo transfers, and when all the 3 develop, it results in a triplet pregnancy. And as you all know, that the complications will be very high in any form of a multiple pregnancy. It could be twin or it is triplet pregnancies. So in order to reduce the complications, what they do is, of course, with the consent of the patient and proper counseling, in case of triplet pregnancies, they use KCL for fetal reduction, where they inject this KCL into one of the fetal sacs and they reduce one of the fetuses from triplet pregnancy to either a twin pregnancy or a singleton pregnancy, depending on the choice of the patient. So this is one important indication for KCL in obstetric. Remember, it is used in ectopic pregnancy and it is used in fetal reduction, right? So coming to the other drugs, so methotrexate in KCL is used. Any other drug is used for the medical management of ectopic here? Anybody?
Option D.
Yeah, D, that is mifepristone and even actinomycin D. So all these 4 drugs are used. HCG is definitely not used. And what you all have to remember is the most commonly used drug is methotrexate. Okay.
B used.
Yeah, actinomycin D is also used. See, methotrexate and actinomycin D are all, these both belong to the chemotherapeutic drugs, is it not? So they do affect on the growing tissue. So there have been trials where they've used methotrexate. When it has failed, they have also tried with actinomycin D in few studies or trials. But the results are much better with methotrexate. So that's why this is the most commonly used one. But there are trials where they have used actinomycin D, even RU486, that is mifepristone. It is actually anti-progesterone agent. Now, how it acts on, in medical termination of pregnancy, we have discussed in the previous classes that mifepristone is used for medical abortion, in the therapy or in the regimen. So similarly, it has an anti-progesteronic effect, and it has been tried in ectopic pregnancy as well, with varying results, of course. So all the 4 drugs are used in ectopic pregnancy. Clear to all of you?
Yes, ma'am.
We move to the next one. Which of the following drug is not used for medical management of ectopic pregnancy? Potassium chloride, methotrexate, actinomycin D, and misoprostol. This is a very easy question.
Misoprostol.
Yes, D, misoprostol. What is misoprostol?
Prostaglandin.
What is misoprostol?
PGE1.
PGE1. So where is it used? PGE1, misoprostol? What are the indications of misoprostol in obstetrics?
For abortion.
Yeah, it is used in abortion. Where else it is used?
PPH.
PPH, very good. Then where else it is used? Yes? It is also used for the induction of labor, is it not? So small doses, in the doses of 25 to 50 micrograms every 4th or 6th hourly, depending on whether it is a primigravida or a multigravida, we use misoprostol for induction of labor also. Okay. And of course, for MTP, abortion, medical abortion, and as you told, for PPH, we use misoprostol. Okay. Next one. So what you have to remember in the medical management is there are a number of chemotherapeutic drugs which are used. They can be given systemically, that is IV, or directly into they directly inject these drugs into the ectopic gestational sac. So that is called as surgically administered medical management, or SAM. And it is done usually under sonographic guidance or a laparoscopic guidance. So which are the drugs commonly used for medical management is, as we discussed, methotrexate, prostaglandins, very rarely used, pre-GF2 alpha, hyperosmolar glucose, mifepristone, actinomycin D, vasopressin, and KCL have all been tried for SAM. Whereas for systemic, most of the times it is only methotrexate along with leucovorin. It is used in a combination to avoid the side effects. So both together are used in the systemic route of administration of the drugs. So this you have to remember. Next question. In which of the following conditions the medical treatment of ectopic pregnancy is contraindicated? Sac size is 3 centimeters, blood in the pelvis is 70 ml, presence of fetal heart activity, previous ectopic pregnancy. There are certain criteria based on which you will decide whether you can try for the medical management for this patient or no. So you all have to remember those criteria, and there are a number of questions based on these. So coming to this question, what is the answer? Anyone? Which is the most important, contraindication amongst the 4 which is mentioned here? Anybody with the answer?
Option C.
Yeah, C is the right answer here. Amongst these 4 options, C is the contraindication for going ahead with the medical treatment, though it is a relative contraindication. Presence of fetal heart activity is a contraindication for medical treatment. Whereas when the sac size is 3 centimeters or when there is hardly 70 ml blood in the pelvis, or even if there is a previous ectopic, we can still go ahead with the medical treatment. Okay. Now, a few important points regarding medical management. You have to remember the drugs. The drug which is most commonly used is methotrexate, and it is a folic acid analog which inhibits dehydrofolate reductase and prevents the synthesis of DNA. So what is the criteria for the candidates for methotrexate? Absolute requirements are that the patient should be hemodynamically stable. There should be no evidence of acute intra-abdominal bleeding. The reliable commitment has to be there from the patient, and she has to comply with required follow-up care when you are doing the medical management for any patient. No contraindications to treatment to the woman should be there. That is like she should not be breastfeeding, or there should not be any renal or hepatic dysfunction. So these are the absolute requirements for methotrexate treatment. Preferable requirements is absent or mild pain in the patient, serum beta HCG level less than 10,000 international units. Best results have been demonstrated when the HCG level is less than 2,000 IU per liter. And it is the single best prognostic indicator of treatment success, actually. That is the beta HCG levels. The absent embryonic heart activity, ectopic gestational mass less than 4 centimeters in diameter without cardiac activity and 3.5 centimeters with cardiac activity. Fetal cardiac activity. Now, important point to remember here is, although it is a relative contraindication to medical therapy, the admission is based on the limited evidence, in the sense that even though fetal cardiac activity is a relative contraindication, but most of the times whenever they have tried the medical therapy in the presence of cardiac activity, there have been very few successful therapies. So that's why they mention it with admission with limited evidence. The presence of embryonic heart activity is not an absolute contraindication for medical management, but the likelihood of failure and the risk of tubal rupture are substantially increased. Therefore, it is a relative contraindication according to Leon-Spiroff. So the questions and the options, whatever they have given, it will all depend on those factors. And based on those, you will have to make an informed and important choice for the particular question. So if they have mentioned that the cardiac activity being a relative contraindication, then you will have to tick the choice accordingly. Now, another important things to remember is, as far as fluid in the cul-de-sac is concerned, earlier it was also considered a relative contraindication to the medical treatment, but studies have shown that free peritoneal fluid can be seen in almost 40% of the women with early unruptured ectopic pregnancy, and therefore its presence or absence does not accurately predict the success or failure of the medical treatment. What is more important than just the presence of the fluid in the POD is the hemodynamic status of the patient. So whenever the hemodynamic stability of the patient is it has to be considered as the first important criteria for selecting the patient for medical management, rather than just seeing for the presence of the any collection within the POD in case of an ectopic pregnancy. So other important things you remember, what are the contraindications for methotrexate treatment is breastfeeding, immunodeficiency states, alcoholism or evidence of chronic liver disease, renal disease, hematological abnormalities like severe anemia, leukopenia or thrombocytopenia, known sensitivity to the methotrexate, active pulmonary disease, peptic ulcer disease, and if there is evidence of tubal rupture, definitely it is contraindicated. So these are some points to remember. Now, other important points is medical therapy fails in about 5 to 10% of the cases. Until the ectopic pregnancy is resolved, sexual intercourse is prohibited whenever you are putting the patient on the medical therapy. Alcohol should be avoided, and any folic acid supplements, including the previtamins, should not be taken. Okay, so these are the important points to remember when you are doing the medical therapy for the ectopic. So how do we give the regimen is most commonly we use a single dose of methotrexate, and it is given on day 0 or day 1, then day 2, day 4 and day 7 are when we follow it up. So on day 1 or day 0 at the admission, we measure all the important parameters of the patient. The blood tests are done. Once all these tests are within the normal limits, then we go ahead on the second day and give a single dose of methotrexate, that is 50 milligrams per square meter of the body. It is given in the IM. Okay, it is given. Then on day 4 we assess the beta HCG levels and counts are repeated, and again on day 7 the beta HCG and the counts are repeated. So how do we follow up that whether the treatment is successful or no is when the beta HCG level on day 7 from day 4 is decreased by more than 15%. Okay, remember when the decline in the beta HCG level from day 4 to day 7 is more than 15%, it indicates that the medical therapy is effective and no further treatment is required, and we can follow up the patient with beta HCG levels weekly until it is undetectable actually. Okay, now if the fall in the beta HCG level is not more than 15% or it is less than 15%, or if the fetal cardiac activity is still present in spite of giving the methotrexate, then what we can do is we can repeat the methotrexate dose as we gave on the day 1. We repeat the methotrexate dose. If in spite of giving the second dose, if there is no response, then surgical treatment is what we have to look for. So surgical treatment is indicated if the beta HCG levels do not decrease or if fetal cardiac activity persists after even 3 doses of methotrexate, but we practically do not go up to 3 doses of methotrexate. So maximum we can go for a second dose, and if that fails, we go ahead with the surgical treatment rather than waiting for a longer period of time. So these are some of the important points you have to remember regarding the medical management of ectopic pregnancy. Now, surgically administered medical management, methotrexate can also be administered by direct local injection, that is 1 milligram per kg into an ectopic gestational sac under laparoscopic or ultrasonographic guidance. The method will deliver a high concentration of drug at the site of the implantation. The results with this therapy are inconsistent, and the success rates are also inconsistent. That's why it's not much preferred, and another disadvantage is that it requires a high technical skill, and it is ultrasonographic dependent. That's why it's not a preferred method. So best is to go for a systemically administered methotrexate rather than surgically administered one. So is it clear to all of you? Greater than 1500 or beta HCG less than 15,000?
Live streaming is on.
What is the indication for medical management in ectopic pregnancy amongst these 5? Yes, students? We just discussed this, is it not now?
B.
Yeah, B is the right answer. When the gestational sac, the size here, it indicates the size of the gestational sac should be less than 4 centimeters. This is one of the important criteria for medical management, whereas all others are not. So as I told, presence of fetal heart activity is actually a relative contraindication, but it is a contraindication. So this will not be counted. And of course, gestation sac less than 6 weeks or beta HCG level of such high levels is definitely not an indication. So the answer for this question is size that is less than 4 centimeters is the right answer. Okay, now next one. A hemodynamically stable nulliparous patient with ectopic pregnancy has an adnexal mass of 2.5 by 3 centimeters and beta HCG titer of 1500 milli-internationals per ml. What modality of treatment is suitable for her? Conservative management, medical management, laparoscopic surgery, or laparotomy? Read the question again and tell me the answer. There are a lot of important points put up here. Hemodynamically stable. Okay, so this is one important point you'll have to see for what kind of modality you want to go for. So the patient is hemodynamically stable and the adnexal mass of the gestational sac is just 2.5 by 3 centimeters. Okay, and the beta HCG titer is just 1500 ml. 1500 milli-international units. So all these criteria will fit for what kind of management and what is ideal for her? Once the patient is hemodynamically stable, it shows that it is an unruptured ectopic pregnancy, is it not? It's an unruptured pregnancy, unruptured ectopic pregnancy. Therefore, you can definitely go either for a conservative management or a medical management for such cases. Yes or no? She
Yes.
doesn't immediately need a laparoscopic surgery or a laparotomy, right?
Yes,
So
ma'am.
now coming to these 2 points, that is conservative management or medical management. Remember, conservative management is always risky, or expectant management, what we call, is always risky, and the patient has to follow up properly. And most of the times it usually fails and ends up in ruptured ectopic if we do not follow up properly. That's why what we prefer in such cases, when you're catching them early in the unruptured state, the patient is hemodynamically stable, small sac, and the HCG is also lesser. It's a perfect case for your medical management. So you can right away go for the medical management. Of course, the drug of choice is methotrexate, and you can follow up the patient. So the answer for this question will be medical management. Is it clear to all of you?
Yes, ma'am.
Okay. So next one. Another important points what you have to remember amongst the 3 important modalities for ectopic pregnancy, let us discuss here. So as we discussed, there are 3 important modalities. One is the expectant management, then you have the medical management or the surgical management. Now, what do you do in expectant management? It is only observation, right? So you hope for a spontaneous resolution. When you do that, that is indication when the decreasing serial beta HCG level titers, tubal pregnancy, it is only tubal pregnancy. That means it is not an ovarian pregnancy or an abdominal pregnancy or anything like that. It's only the tubal pregnancy. No evidence of intra-abdominal bleeding or ruptured assessed by vaginal sonography. And the diameter of the ectopic mass is less than 3.5 centimeters, preferably less than 3 centimeters. So these are the criteria for expected management, and you just do it in the hope that it will spontaneously resolve, but with a very high monitoring of the patient for any rupture, signs of any rupture. Now, medical management, we use methotrexate. What are the criteria? As we discussed earlier, the patient should be hemodynamically stable. There should not be any evidence of acute intra-abdominal bleeding. Reliable commitment to comply. No contraindications to the drug or the treatment. Preferable requirements is absent or mild pain in the patient. Now, surgical management, it is done in all those patients who do not fulfill the criteria laid down by the medical management, and it should be done in all cases of ruptured ectopic. So these are the 3 important modalities. So what are these criteria which are not laid down? In the sense that there could be gestational sac more than 4 centimeters, there could be fetal heart rate, or the adnexal mass could be higher, or there could be a huge rupture with the collection within the POD. So these are some of the criteria where the patient is directly taken up for surgical management and rather waiting for a medical management. So these are the options. Now, what are the surgical management options available? Most of the times it is laparoscopy, what we do nowadays, where the patient is hemodynamically stable, and it's a very quick in and quick out procedure. The patient recovers very well immediately. The next 2-3 days we discharge her, and either the salpingectomy or based on the damage to the tube, the procedure is done in laparoscopy. Laparotomy, of course, where the facilities for laparoscopy is not available nowadays, only the patient will be undertaken for laparotomy. Again, the patient should be hemodynamically stable. Of course, this is not a criteria where even hemodynamically unstable patients we have to go for laparotomy, and ruptured ectopic is the preferred pregnancy. So I think there is some miscommunication here. These points are not proper. So in ruptured ectopic, or even if the patient is hemodynamically unstable, we go ahead with a laparotomy, not otherwise. So hope it is clear to all of you students, different aspects of management of ectopic pregnancy. Yes. Now, what are the additional criteria for expectant medical and surgical management? You have to remember where the beta HCG baseline should be less than 1000 for expectant management, and it should be in a falling trend. And the best results are obtained if the beta HCG level is less than 200. In medical management, the serum beta HCG level should be less than 10,000. Best results are seen with the HCG levels are less than 2,000. There should be an absent embryonic heart activity, and ectopic gestational mass should be less than 4 centimeter in diameter. In surgical management, when there is an extensive abdominal and pelvic adhesion, you have to, where the laparoscopy is difficult, you can go for a laparotomy directly. Or when you are suspecting a coronal pregnancy, an interstitial pregnancy, or an abdominal or ovarian pregnancy, you have to go ahead with a laparotomy. Okay, so these are the important criteria, again, points to remember. Now, the above patient, what we discussed were these points, and we came to the answer that she might be, the expectant management is the best answer for her. So is it clear to all of you regarding the different management aspects of ectopic pregnancy? Now,
Yes.
two important points what you have to remember is, I've quoted from the Williams and other textbook, is the potentially grave consequences of tubal rupture coupled with established safety of medical and surgical therapy require that expectant therapy be undertaken only in appropriately selected and counseled women. So when you're doing an expectant therapy, it is very, very important that the patient should be counseled, followed up properly for any further complications. Now, minimal side effects of methotrexate make it preferable to avoid the prolonged surveillance of expectant management, and therefore most of the times we prefer a medical management rather than an expectant management in most of the patients, right? Now coming to the next question. A female has history of 6 weeks amenorrhea. Ultrasonography shows empty sac. Serum beta HCG level is 6,500 international per liter. What would be the next management? Medical management, repeat HCG after 48 hours, repeat HCG after 1 week, or surgical management? Yes, students? So first of all, what is the diagnosis in this case? A female with a history of 6 weeks amenorrhea. USG shows empty sac. Actually, it is an empty uterus probably. And serum beta HCG level is just 6,500. What would be the next management? So if you consider it as an unruptured ectopic pregnancy, the diagnosis being the unruptured ectopic pregnancy, what kind of management would you prefer? Now that we have learned different aspects of each kind of management for ectopic, we have learned when
Medical.
we have to do expectant, when we have to do medical, and when we have to do a surgical management. So what would you want to do in this patient?
Medical management.
Medical, is it not? So this patient fits in the criteria for medical management definitely, though they have not mentioned any other features. But when there is a patient who is hemodynamically stable with all these features, that is 6 weeks gestational sac, empty uterus, and HCG is also lower side and 6,500, we can still go for medical management. So the answer for this will be medical management. Okay. Next. A 20-year-old woman has been brought to casualty with a BP of 70 by 40 mmHg, pulse rate of 120 per minute, and a positive urine pregnancy test. She should be managed by immediate laparotomy, laparoscopy, culdocentesis, or resuscitation and medical management. So what do you think about this patient? BP 70-40 with 120 pulse means what?
Hemodynamically unstable.
Yeah, the patient is hemodynamically unstable. She's in shock, right? And a positive urine test, positive urine pregnancy test, and the patient in shock. What are the conditions which come to your mind whenever you see a patient like this? Though they have not given
Ruptured
any other
ectopic
history, whether she's
pregnancy.
bleeding, not bleeding, and all that, but a patient with a positive urine pregnancy test and coming in shock, most of the time in early pregnancy, what are the conditions which come to your mind?
Ruptured ectopic and
Most common is an abortion actually, especially incomplete abortion, where the patient is having a UPT positive, and if she's having a heavy bleeding, then she'll end up with shock sometimes. But they haven't given anything here as such with respect to other symptoms like PV bleeding or anything. So if we consider this and the options here, if you consider the options, they've given laparotomy, laparoscopy, culdocentesis, or resuscitation in medical management. That means they're looking at which condition? They're looking at ectopic pregnancy. Is it no?
Unruptured ectopic.
Yeah. So now the patient is in shock, hemodynamically unstable. So it definitely indicates a ruptured ectopic. So in ruptured ectopic, what is the treatment of choice?
Surgical.
Surgical, correct. So amongst surgical, whether you want to go for a laparotomy or a laparoscopy for this patient?
Immediate laparotomy.
Yes, because as we mentioned, laparoscopy cannot be done in hemodynamically unstable patients, right? So whenever there is a hemodynamically unstable patient with a ruptured ectopic, laparotomy is the surgical choice, right? So the answer for this question is immediate laparotomy, okay? So yeah, this is what we discussed, and it's what the answer we've chosen. Next question. Which of the following treatment is not done in ectopic pregnancy? Salpingectomy, salpingo-oophorectomy, salpingostomy, resection of the involved segment. Salpingectomy is what? What is the procedure for what of salpingectomy? Salpingectomy means it is
Removal of fallopian
removal
tube.
of the tube, right? What is salpingo-oophorectomy?
Tube with the ovary.
Tube with the ovary. Salpingostomy. What is salpingostomy? Ostomy means you're just cutting open the tube there, right? You're cutting open the tube, removing the contents of the ectopic, and then kind of suturing it. That is salpingostomy. Okay. In the resection of the involved segment is what you do is you remove the only that part of the tube which has got affected, and the rest of it you leave it. So that is resection of the involved segment, or it is also partial salpingectomy, right? So what is the question? Which of the following treatment is not done in ectopic pregnancy? You do salpingectomy or no?
Yes, ma'am.
Yes, you have to do, is it not? So whenever there is a damaged tube, completely ruptured, you have to take out that tube to completely attain the hemostasis. So you want to stop the bleeding there. That is your primary intention in ectopic pregnancy. So when there is a highly damaged tube, you can't leave it alone there. You have to take it out. So that is salpingectomy is done, and it is actually the most common procedure what we do in a ruptured ectopic pregnancy. So salpingectomy is done. Do you do salpingo-oophorectomy in all the cases of ectopic pregnancy? Yes or no? Do you want to remove the ovary also in all the cases of
No, ma'am.
salpingectomy? No, is it not? So we do not do salpingo-oophorectomy in all the cases of ectopic. We do not want to remove the ovary unnecessarily. We want to keep it. And only if there is an ovarian pregnancy and if the ovary is damaged beyond, repair, or if we cannot keep even a little bit of tissue of the ovary, we completely remove the ovary in case of ovarian pregnancy. So there is only in such conditions we go for salpingo-oophorectomy. Otherwise, we do not. So the answer for this question is actually salpingo-oophorectomy, which is not done in ectopic pregnancy most commonly, whereas other three surgeries are commonly done: salpingectomy, salpingostomy, and resection of the involved segment. Okay, clear to all of you?
Yes, ma'am.
Fine. So now regarding the surgical managements, you have to remember there are two types of surgeries. One is conservative surgery and the radical surgery. So what are the procedures we do in conservative surgery where the tube is kind of left behind? We do not salvage the tube. So these conservative procedures are done specially in case of primi gravidae or who are where the tube is healthy, the rupture is linear, and we are able to conserve the tube. Only in such cases we go ahead with the conservative procedures for the surgeries. So they are salpingostomy, as I discussed, where the procedure is where the patient is hemodynamically stable and she of course wishes to retain her future fertility, and the tube is of course not that damaged so that we could continue with the salpingostomy, right? So this is one procedure. Then salpingotomy is where we kind of open it up and then reanastomose with together. It's done very rarely nowadays, and only in case of an ischemic pregnancy, ischemic ectopic pregnancy, it is done. Where what they do in ischemic portion of the tube, the diameter of the tube is very even, is it not? So when you remove that and if you have proper edges to suture them back or resuture them back, then we do the salpingotomy, and mainly in the ischemic kind of a pregnancy we do it. Fimbrial expression of the ectopic pregnancy is where the ectopic is there in the fimbrial end and we just kind of express the and push it out through the fimbrial end. So that is again depends on how much is the tube damaged, and if it's a very small tissue we push it out, and if there is no active bleeding then we can go ahead with such a procedure. But always remember the risk of recurrence of ectopic pregnancy are very high, therefore all these procedures are not very commonly performed nowadays. Radical surgeries which we do in such cases are salpingectomy, as we discussed, and the indications are ruptured ectopic. The patient has completely completed a family, the tubes are grossly damaged, the ectopic has recurred in a tube already treated conservatively, or there is uncontrolled bleeding, or the sac size is more than 5 centimeters. So all these points are indications for a radical surgery. That is nothing but most of the times what we do is salpingectomy, that is removal of the tube. So as I discussed, salpingo-oophorectomy is the removal of the tubes along with the ovaries, and it is not recommended in young patients. Presently, salpingo-oophorectomy is never recommended unless the ovary itself is grossly diseased or damaged. The ipsilateral ovary, that is the other side ovary, vascular supply is preserved, and oophorectomy is if the ovary is damaged beyond salvage or is pathological. So these are some of the important points you have to remember. Now, how do you follow these patients? Is of course by estimation of beta HCG, which is weekly, and the value should come less than 5 per international units. And additional monitoring by Dr. Milford, which is done to rule out persistent ectopic pregnancy due to incomplete removal of the trophoblast. In such a case, single dose of methotrexate 1 milligram per kg should be given. This is again post surgery. We do sometimes methotrexate when there is a huge tissue and it has got attached to the adjacent structures in the pelvis, and we remove it piecemeal, and we still feel that there is some amount of tissue left which is attached to the ovary, or it is attached to the important other structures. Like sometimes the bowel also get attached. So in that case we remove it piecemeal and we leave some amount of tissue over the bowel or over the ovary, and post surgery we again give the patient methotrexate so that some amount of the tissue whatever has been left will be treated by the medical management. So these are some of the special cases where we need to give post-operative methotrexate. Okay. Now the next question. In a nulliparous woman, the treatment of choice in ruptured ectopic pregnancy is salpingectomy and end-to-end anastomosis, salpingo-oophorectomy, wait and watch, or linear salpingostomy. Yes, students? B and C are ruled out, of course, is it not? We don't go for salpingo-oophorectomy or wait and watch in this case. So we are left with either salpingectomy with end-to-end anastomosis or linear salpingostomy, which is ideal in this case in a nulliparous woman.
D.
And remember what they've asked is in ruptured ectopic. So which is the ideal procedure, salpingectomy or linear salpingostomy in a ruptured ectopic? Yes, students? Anybody?
D.
Are you there with me, all of you? D is actually not the wrong, it's not the right answer. See, we cannot do a linear salpingostomy when there is a ruptured ectopic. Linear salpingostomy can be done only when there is a unruptured ectopic. Linear means you take a nice incision on the tube, open up the tube and drain out the ectopic tissue and then close it back. That is actually salpingostomy, linear salpingostomy. But in this case, remember they've asked in a ruptured ectopic, and linear salpingostomy is not a procedure where you could do that. So the answer is actually A, that is salpingectomy, and end-to-end anastomosis can be tried for a nulliparous woman. If it were to be a multiparous woman with completed family, ruptured ectopic, then we directly go with salpingectomy only. We don't do an end-to-end anastomosis there. But here, since she's a nulliparous, she wants to retain her fertility, the end-to-end anastomosis can be tried in such cases. Clear to all of you?
Yes, ma'am.
Right, next one. Management of unruptured tubal pregnancy includes methotrexate, prostaglandins, hysterectomy, laparoscopic salpingostomy, or salpingectomy. Remember again here a PGI question, more than one option will be the right answer.
A, B.
A, of course, methotrexate is correct in unruptured tubal ectopic. B, of course, prostaglandins also have been tried as we discussed earlier. Any other answer? Hysterectomy is definitely not the answer here. Salpingectomy is not the choice in unruptured tubal pregnancy. Remember, they've asked for unruptured tubal pregnancy. Right, so D also is the right answer here. That is laparoscopic salpingostomy can also be done for an unruptured tubal pregnancy. As I mentioned, salpingostomy is where we open up the tube, take a linear incision on the tube, open up the tube and drain out the ectopic tissue and then suture it back. So that is salpingostomy. So in case of an unruptured pregnancy, we can go ahead with salpingostomy. So these three options, that is methotrexate, prostaglandins and laparoscopic salpingostomy are the right answers for this question. Clear to all of you?
Yes, ma'am.
Yeah. Next one. Not true about ectopic pregnancy. Not true. Previous ectopic is greatest risk. Progesterone only pills doesn't increase risk. Increased risk with pelvic infections. Increased risk with IVF. IUCD increases the risk. So not true means they're asking the false statement here. Which is the false statement? Previous ectopic, does it increase the risk of ectopic?
No, ma'am.
Yes.
Yes,
Yes,
it does
ma'am.
increase. Okay, so it is actually one of the important risk factors for ectopic. So whenever a patient is giving history of previous ectopic, you should be doubly suspicious for this patient in this present pregnancy for ectopic, right? So previous ectopic is a very important risk factor for repeat ectopic. Now, second one, progesterone only pills doesn't increase risk. Is it true or not true? Progesterone only pills doesn't increase risk of ectopic pregnancy.
Yes, ma'am. Ma'am, it does increase.
It does increase, is it not?
Yes, ma'am.
So it is not a true statement. That means it is a false statement. See, this question is very tricky here. They have asked not true here, that means false, and then they have put up another negative word here, that is doesn't, to just make you confused. So what you should do in that case is to look at the other options. Okay, see, increased risk with pelvic infections, yes or no? Yes, that's a true statement, is it not? So with pelvic infections, the risk of ectopic definitely increases. With IVF, the risk of ectopic is increased or no?
Yes, ma'am.
It is increased, definitely, is it not? With IVF, what we do is we induce with the multiple, like ovulation induction is done and multiple eggs are released. And of course, multiple embryo transfers are done, and there are very high chances of ectopic again in IVF. So the risk is increased with pelvic infections, with IVF, and also, of course, IUCD. So all these three statements are true, and even the first statement is true. So what you're left with is B, right? And also, if you read it properly, progesterone only pills doesn't increase risk is actually a false statement or a not true statement. Correct? So this is how you might have to come to the conclusion. So here again, your English is tested here, right? Hopefully, whenever there is a question like this. So is it clear to all of you? We'll go to the next one. A female presents with 8 weeks amenorrhea with pain left lower abdomen. On ultrasonography, there was thick endometrium with mass in the lateral adnexa. Most probable diagnosis is ectopic pregnancy, torsion of dermoid cyst, tubo-ovarian mass, or a hydrosalpinx. This is an easy one. A, ectopic pregnancy. 8 weeks amenorrhea, left lower abdominal pain, thick endometrium. See, remember, ultrasonography shows thick endometrium. There is no sac within the uterine cavity. That is again an important point to remember. So all these three things will point to ectopic pregnancy. Why not dermoid cyst? Because there won't be amenorrhea and dermoid cyst. Okay. Tubo-ovarian mass is most of the times, again, there won't be amenorrhea. There could be irregular menstrual cycles or bleeding, and pain could be there, yes, but amenorrhea is not classical in any of these. So hydrosalpinx, tubo-ovarian mass, and dermoid cyst, amenorrhea is not there. And here, important point to remember is 8 weeks amenorrhea, right? So the answer here is ectopic pregnancy. Okay. Next one, test not useful in case of tubal pregnancy. Pelvic examination, ultrasonography, HCG, or hysterosalpingography. This is an easy one. Which test you do not do in tubal pregnancy?
Pelvic examination.
No, pelvic examination is the most important thing what you have to do. See, earlier when there were no ultrasonography, people did not do pelvic examination. That was the only, to diagnose ectopic. One is to feel the adnexal mass. Second is to demonstrate the tenderness in the fornices and demonstrate the tenderness to cervical movements. That's the most important thing which would suggest for an ectopic pregnancy. And feeling the uterus feeling a normal size uterus. For example, if the patient is giving you history of 6 to 8 weeks amenorrhea and the uterus is still normal size when you're doing a pelvic examination. So all these points would help you diagnose ectopic pregnancy. When we have to do a pelvic examination actually as a routine, stepwise procedure for diagnosis. So pelvic examination is an important point, is an important tool to diagnose tubal pregnancy. So you cannot negate it, remember. Okay. So as you know, ultrasound and ECG are definitely done. So what is the answer for this question? It is
hysterosalpingography.
Yeah. Why do you want to do hysterosalpingography? See, hysterosalpingography is done
tubal block.
If there is any tubal blockage in infertility patients, or if you want to diagnose any intrauterine pathology, you do the hysterosalpingography. Is it not? So it's not definitely in the tubal pregnancy. So that's the answer for this question. Test not useful, remember. Okay. Next one, Arias stellar reaction is not seen in ovarian pregnancy, molar pregnancy, interstitial pregnancy, or salpingitis isthmica nodosa. Anyone? Even if you don't know the answer, actually you can just guess in this case. Arias stellar reaction is related to what feature? Like, is it a clinical feature or it's a pathological feature? What kind of a feature is it? If you all can remember even your other subjects, not necessarily obstetrics. Is it a clinical feature or a pathological feature? Yes, students. Anybody with a wild guess for this answer?
A or B, ma'am. Not sure.
A or B, not sure. See, all the options here, whatever they are given, is 3 of them are related to some or the other form of pregnancy. Is it not? Ovarian pregnancy, molar or interstitial, some of the other pregnancy. What is the only odd answer is, odd option is a salpingitis isthmica nodosa. What is the salpingitis ischemica nodosa? Anybody? So you can remember the name itself will tell you. Salpingitis means it is infection of the tube. Okay. Ischemica nodosa means it is probably affecting the ischemic region, and nodosa means nodes kind of lesions will be formed on the tube. Because of repeated infections or infection of the tube gets blocked and node kind of things will be formed all along the tube. So that condition is called as salpingitis ischemica nodosa. Right. So this is a one pathological condition which results because of repeated pelvic inflammatory conditions, especially the infection of the tube. Whereas all other three options here, what they've mentioned is ovarian pregnancy, molar pregnancy, interstitial pregnancy, some or the other form of pregnancy. So if you can just commonly, if you can think of, what could be the possible answer, this is the one which is not related to any of these, right? So even if you guess, you should be able to guess it right, that this is the answer for this question. Yes or no? Yes?
Yes,
So
ma'am.
you should think that Arya-Stella reaction is something related to pregnancy, since these three options are given in the form of pregnancy related conditions. Whereas this is only the odd one which is not related. So this could be the answer. So this is how you can make a guess when you're not sure of the answers. Okay. So let us understand what is this. Now, Arya-Stella reaction is characterized by adenomatous change of the endometrial glands. So it is a histological change, as we discussed. It is a pathological change which is seen in the endometrial glands under the influence of hormones, especially during pregnancies. So there is intraluminal budding of the endometrial glands. Right? Now, cells lose their polarity, have hyperchromatic nucleus, calculated cytoplasm, and occasional mitosis is seen. Now, the reaction is seen in ectopic pregnancy in 10 to 15% of the cases, and it indicates blightening of the conceptus either intra or extrauterine. So, remember, Arya-Stella reaction is seen in blightening of the conceptus. That means when the conceptus or the fetus stops growing, it gets blighted, or it gets it stops growing at a certain stage. The fetal tissue do not develop at all. So that is called as blightening of the conceptus. And it is more specific for this condition, that is blightening of the conceptus. But remember, it is also seen in about 10 to 15% of the cases of ectopic pregnancy. Right? So this is what is the Arya-Stella reaction. It is a histological or a pathological feature which is seen in the endometrial glands. So as I told, it's not specific for ectopic pregnancy, but it is more specific for blightening of the conceptus, either intrauterine or extrauterine. Now, what is salpingitis ischemica nodosa? As I explained, it is a non-inflammatory pathological condition of the tube in which tubal epithelium extends into the myosulfings and forms a true diverticulum. This condition is found more often in tubes of the women with an ectopic pregnancy than in non-pregnant women. Whether tubal pregnancy is caused by systemic ischemica nodosa or whether the association is coincidentally is unknown. So by itself, SIN is not the condition which would give rise to Arya-Stella reaction, but SIN leading to ectopic pregnancy will then lead to Arya-Stella reaction. So according to this logic, the answer for that particular question is D. That is salpingitis ischemica nodosa. Okay. Even in some cases of molar pregnancy and in cases of interstitial pregnancy, which is again a form of ectopic pregnancy, there will be Arya-Stella reaction. Okay. So next one, what is the treatment of choice of unruptured tubal pregnancy with serum beta-HCG titer of less than of 2000 internationals per ml? Single dose of methotrexate, variable dose of methotrexate, expectant management, or laparoscopic salpingostomy? This is an easy answer. We have already discussed about this. What is the right answer? Yes, students? Unruptured tubal pregnancy with HCG titer less than 2000. What do you want to do in such case? Do you want to go for laparoscopy and expectant management? Yes or no?
No, ma'am.
No. So you're left out with these two choices, is it not? You don't want to go ahead with laparoscopy or an expectant management. Now you have left with two choices. Either you want to go with single dose methotrexate or a variable dose. Remember, it's just unruptured and just 2000. So which is the most preferred dosage? Single dose, is it not? So we have already discussed about this. So the answer for this question will be single dose methotrexate is good enough for management of such a patient, right? Now, next one, diagnostic criteria for primary abdominal pregnancy. Now, there are a lot of criteria you should be remembering in ectopic pregnancy, and a few questions have been asked on this. It's quite confusing, so it is always important that you make points on this and remember each of these criteria used for different diagnosis of different types of ectopic pregnancies. So, anybody who knows this answer? Diagnostic criteria for primary abdominal pregnancy is known as which criteria? Anybody? If not, I'll give you the answer and we'll discuss all these points. Anybody? Once more, I'm asking you. It is C, that is Studiford criteria. Okay, so the diagnosis of primary abdominal pregnancy is based on the criteria which is named after Studiford. So let's understand what are these criteria. So whenever you want to diagnose a different kind of an ectopic pregnancy, either it could be an abdominal, ovarian, or a cervical, certain criteria have been put forth. So you have to remember the names. Studiford criteria is used to diagnose primary abdominal pregnancy. So what are the detailed criteria here? Remember, both the tubes and ovaries should be normal without the evidence of recent pregnancy, the absence of uteroperitoneal fistula, the pregnancy must be related exclusively to the peritoneal surface. So these are the criteria for diagnosis of primary abdominal pregnancy and just Studiford's criteria. And what is the management here? You have to go for a surgical management of removal of the ectopic, right? So this is primary abdominal pregnancy. Then ovarian pregnancy is diagnosed by Spiegelberg criteria. And what are these criteria? The tube on the affected side must be intact. The gestational sac must occupy the position of ovary. The gestational sac is connected to the uterus by ovarian ligament. Definite ovarian tissue must be found in the sac wall. So these are the criteria for diagnosis of a ectopic ovarian pregnancy. This is by the name of Spiegelberg's criteria. And of course, the surgical management is the choice for such a case. Next, coming to cervical ectopic pregnancy, it is diagnosed by Rubin's criteria, also called as Pamactic's criteria. So what are these? The uterus is smaller than the surrounding distended cervix. The internal os is not dilated. Curettage of the endometrial cavity is non-productive of placental tissue. The external os opens earlier than in spontaneous abortion. So these are the criteria for diagnosis of a cervical ectopic pregnancy. How do you manage? You can do it either medically or surgically. Medically, it can be done if the patient is stable and if it's diagnosed early and can be tried with methotrexate. Surgical management, if it is ruptured and the patient is unstable, you have to go for a surgical management. So these are some of the different very rare kinds of ectopic pregnancies and important criteria to diagnose them and the management of theirs. So is it clear to all of you? Have you all understood these criteria? You have to remember and make note of all these. Okay. So we come to the end of this session today. This is the last question. Now, angular pregnancy refers to ectopic pregnancy of interstitial part of the fallopian tube, intrauterine pregnancy, heterotopic pregnancy, or ectopic pregnancy of broad ligament. What is the answer? What is angular pregnancy? Anybody? Students, are you there with me? Because I'm unable to hear any of your voices. Hello? I hope there is no disconnectivity.
Yes, ma'am.
Yeah, so please answer this question. It is easier one, no? What do you mean by angular pregnancy? Anybody with the answer? Okay, fine. The answer I'll give you, it is B, actually, intrauterine pregnancy. So any pregnancy which is developing in one of the angles of the uterus that is near to the cornu, that is called as angular pregnancy, not an ectopic pregnancy, remember. So whenever there is an ectopic pregnancy, it will be developing in the interstitial part of the fallopian tube, not within the uterine cavity per se. So even if there is an angular pregnancy, it is still in the intrauterine area only. So that's why the answer for this question is intrauterine pregnancy. Angular pregnancy refers to intrauterine pregnancy, not the any other type of ectopic pregnancies. So is it clear to all of you? Yes, students?
Yes, ma'am.
Yes, ma'am.
So today we have finished the most of the questions on the ectopic, and we have covered almost all the theoretical part of the ectopic. That is, which we started with the definition, diagnosis, the diagnostic criteria, and the different management aspects, different kinds of ectopic pregnancy, and all that. So I hope it has helped you all, and I hope you all have understood the topic thoroughly. Any doubts in this one? Yes,
No, ma'am.
students?
No, ma'am.
Okay, fine. So in that case, what I'll do in the next class is that we'll cover up some more questions on the ectopic pregnancy. But what I'm going to do is I'll put up it as MCQ test for you all. So 2 days before, that is on Tuesday, I think. Tuesday, I'll put up the questions and I want you all to answer them by Wednesday so that I can discuss in the next class, that is Thursday, we'll take up those new questions about this topic. Okay. So for any other issues, or if you want to have any doubts you have and you want to clear, you can always get in touch with me through the WhatsApp group. Okay.
Okay, ma'am.
Fine. So thank you all students. We'll just end today's session here. I hope it was very helpful to all of you, and any feedback, you're always welcome. Please inform your friends to join this series of NEET and PG coaching. So thank you all again and have a good evening. Thank you, sir.
Yes, madam.